Hi everyone. We're going to talk about substance abuse. This is Darby and Walsh, chapter 56 for the 5th edition and 52 for the 4th edition, I believe. These are the objectives for this chapter. So what to consider when filling out your patient history form. So this is just a little quick slide to kind of get you thinking about that this is basically the section where when we're asking our patients, do you smoke or chew tobacco, and what type of tobacco? Do you drink alcohol? Do you use marijuana? Do you use illegal or street drugs? Those questions that are on the on your history form when you're filling it out. You know, if your patient does respond yes to one of those, then what are you going to say in response? Or if they say no, but you're picking up some pretty strong signals that make you think otherwise, what are you going to do from there? So kind of starting to think about those things. Substance misuse is sort of the current term. It used to be drug abuse or substance abuse, but it's really kind of considered a little bit more of an older, possibly less sensitive term to call it abuse. So substance misuse is a pattern of self-administered drug use that may lead to drug addiction. And a substance is any psychoactive compound with the potential to cause health problems, substance abuse disorders, or substance use disorders, and then addiction. And pretty much you can break it down into 3 categories. You can break it down into alcohol, illicit drugs, and then over-the-counter drugs as well. So the term substance misuse, like I was mentioning in the slide before, is a term that's roughly equivalent to substance abuse. Substance abuse is an older diagnostic term, and it was defined as use that is unsafe, such as drinking while driving or something like that. Use that leads to a person to fail to fulfill their responsibilities or get them in legal trouble, or use that continues despite causing persistent interpersonal problems like household fighting or some kind of personal issues, keeping you from doing a good job at work or even showing up to work. However, substance abuse is increasingly avoided by professionals because of its sort of negative connotation. And instead, substance misuse is now the preferred term. So although misuse is not a diagnostic term, it generally suggests use is a manner that could cause harm to the user and those around them. So a doctor might not use that as a diagnostic term, substance misuse, but it's sort of more of a social description of the condition, that a person is using some kind of an alcohol or illicit drug in a way that's causing harm in their personal life or to other people. So research has shown that drug addiction is a chronic cyclical disease, yet unlike other diseases, it still has this social stigma. So we still think somehow people are weak or just a bad seed or just, a troublemaker or, just whatever we want to label. There is still that social stigma instead of kind of that recognition that it is a cyclical disease. Poor oral health is very common among those with substance misuse problems. Substance misuse directly affects oral health, such as oral manifestations such as xerostomia, increased caries, enamel erosion, periodontal disease, and poor self-care in general. So a couple terms: addiction, dependence, withdrawal, and relapse. Drug addiction is the prolonged, repeated misuse of any substance, a chronic and compulsive need to use drugs despite their causing user physical harm. They just feel like they just can't not do it, even though they are also feeling some harmful effects. Psychological dependence is rooted in the belief that the drug is needed to maintain a state of well-being. So physiological dependence results from a biologic alteration in the user's brain from the consistent drug use. So something is actually physiologically changing because they're consistently using the drug. A person who has developed physiological dependence on a drug will go through drug withdrawals when the drug use stops. Withdrawal symptoms may include vomiting, diarrhea, rapid pulse, sweating, anxiety, convulsions, severe cramps, high blood pressure, severe headaches. It can be physically dangerous, but at the very least, incredibly uncomfortable. Another aspect of physiological dependence is the development of drug tolerance, whereby the increasingly larger dose is required to produce the same physiological or psychological effect obtained earlier with the smaller doses. So they got to use more and more to get the same effect. Here's kind of a little flow chart. Social drinking it can, you can just be a social drinker, but that can lead to problems with abusive drinking, which can lead to, such as problem with abusive drinking could be examples such as frequently blacking out. So drinking so much that you black out during parties. That could lead to dependence. And once you reach that dependent state, you're sort of in the altered brain function. Once you get into that altered brain function, now you're into excessive and uncontrollable drinking, which is sort of a flow chart that leads down to, you might say, okay, we gotta stop this. This is just, I have to stop. I have to just abstain from it completely. But then you get into this acute, protracted withdrawal symptoms, horrible discomfort, horrible feelings that you can't just really feel like you can control, and then you go right back into relapse. So then you go back into that excessive, uncontrollable drinking. So here's a diagram of some of the withdrawal symptoms, the nausea, anxiety, vomiting, depression, sleep problems, just to name a few. Illicit drugs versus over-the-counter. So illicit drugs are a variety of drugs that are used for non-medical purposes and are illegal to manufacture, use, or sell. Over-the-counter drugs, those are drugs that are available to purchase without a prescription. Drugs, certain substances, and chemicals are classified into 5 categories or schedules, and you can look that up or you can see it in the text. There's been a lot of talk about how marijuana has always been, like one of the higher, it's been in the same category as, something like, I think it's like heroin, something that's very, has a lot more, almost what you might consider like potency or a tendency to cause harm or overdose, things like that. And so sometimes the schedules that these categories or schedules that these drugs are in have been under criticism or under kind of thinking about repurposing some of them. So I'm not testing you on any of it, but if you want to look more into that, there is a table in the chapter that goes over the schedules. It's interesting to note which type of drug is in which schedule. So alcohol is the most pervasive substance used in the U.S. It's associated with negative overall and oral health-related diseases and deaths. The liver breaks down alcohol at about 1 standard drink per hour, so it's important to know what a standard drink is. And about 1 in 8 adult Americans, or almost 13% of the U.S. population, meets the diagnostic standard for alcoholism. That's quite high. So here's your one standard drink. So 1 12-ounce beer, 8 or 9 ounces of a malt liquor, 5 ounces of wine, and then a shot or 1.5 ounce of an 80 proof distilled spirit. That's about your one standard drink, and it takes about an hour for your liver to metabolize that. Alcohol poisoning is slow. What it manifests as is slow or irregular breathing, cold, pale, or blue-toned skin, lack of oxygen, rapid pulse, vomiting while awake or asleep, unresponsive to attempts to wake up, semi-consciousness or unconscious altogether. So signs of alcohol abuse, redness of the facial skin, spider petechia on the nose from dilated blood vessels, yellowish skin from like a jaundice related to liver disease, facial trauma, perhaps from falling while intoxicated, angular cheilitis related to vitamin B deficiency, red or swollen eyes. Intoxication looks like poor judgment, impulsive urges, slurred speech, unsteady gait, lack of coordination, impaired memory or attention, involuntary rapid eye movements. We've all probably experienced or seen intoxication. So that's nothing usually new to most people, but it's important to think about it in a different context. Being at a party or being with friends and getting, mildly intoxicated may feel or look different than if a patient walks in off the street for a dental appointment and is intoxicated. It can kind of throw you off guard, and it's like, is this person intoxicated? I've had this happen before, and you almost don't recognize it as the same thing because it's such an environment that you wouldn't expect someone to be intoxicated. So marijuana is the most commonly used illicit drug in the United States. As of April 2017, 29 states and the District of Columbia have legalized medical marijuana use. Research suggests there's potential therapeutic value of marijuana use in positively affecting several health conditions such as pain, nausea, epilepsy, obesity, addiction, and autoimmune disorders. So other names for marijuana or for cannabis would be pot, hash, weed, grass, dope, reefer. Reefer is pretty dated. Not many people call it reefer. There's the chemical compounds, or THC, which is the Tetrahydrocannabinol, and then the cannabinoid. Psychoactive ingredient and analgesic, anti-inflammatory. These are all properties of cannabis. There are short-term effects, could be relaxation, euphoria, possibly confusion. Red bloodshot eyes is often seen. People get what they call the munchies or the cotton mouth. You get intense kind of hunger, or you get thirsty. Difficult with concentration, although some people actually concentrate incredibly well when they use marijuana. So I feel like that can go both ways. Memory, learning, and problem solving can be an issue. Distorted perception of sight, sound, and time and touch can be affected, especially with the psychoactive part of it, THC. Systemic side effects, you can get those dilated pupils, tachycardia, peripheral vasodilation, brachial hyperactivity, insomnia, impaired short-term memory, disruption of testosterone secretion, decreased nausea, and decreased pressure behind the eye. So there's a lot of systemic effects to cannabis, and they're studying it more. It comes in so many forms, especially nowadays with all this kind of surgence of medical marijuana and all these shops. We can see it in just all sorts of different edible forms. There's the vaping and the just different ways of getting it ingested, basically. Then there's hash, and there's these powder forms, and the hash oil, waxes, liquids. There's just a number of ways of. There's CBD ointments and creams and all sorts of different ways of vehicles, I suppose, to get cannabis into the system. But since marijuana is federally classified still as Schedule I substance under the Controlled Substance Act, distributing it is still considered a federal offense. So there's a lot of changes happening, and I think things are going to change in the near future too, but we have to stay updated on all those laws and regulations. So opioid crisis, public health crisis. So there has been a lot of talk about this in CE courses, in articles written in dental and dental hygiene magazines about the opioid crisis. So opioid analgesic pain relievers are now the most prescribed class of medication in the U.S., with almost 290 million prescriptions written each year. Both systemic drugs and opiate drugs derived from the opium poppy plant. And examples would be heroin, which is illegal, Oxycontin, Vicodin, Fentanyl, methadone, hydrochloride, morphine, sulfate. Intoxication is extremely dangerous. Mood swings, impaired judgment, attention, memory, change in pupil size, slurred speech, drowsiness, hallucinations. And of course, just going unconscious and suppression of the respiratory system. So opiates can depress breathing by changing the neurochemical activity in the brain where autonomic body functions are controlled. And that's what makes them so incredibly deadly and scary to overdose. Opiates can change the limbic system, which controls emotions to increase feelings of pleasure. That's another part that makes it scary, is that it makes you feel so good. And, so that's why people abuse it or can overdose. Opiates can block pain messages that transmit through the spinal cord from the body. So you can see there's these two effects that you can see why people would become addicted, but it's incredibly dangerous and can lead to death quite easily with overdose. So the limbic system here, little red kind of little C-shaped area. The C-shaped limbic system of the brain includes portions of each lobe of the cerebral cortex and is essential for memory function, learning, emotion, and motivation. Many of the responses of the limbic system are autonomic and include unconscious body functions. Understanding the limbic system assists clinicians in addressing involuntary and unwanted behaviors of addiction. So psychoactive drugs disrupt the normal functioning of the neurotransmitters. Sometimes this is a desirable effect if we think about it in terms of dulling or weakening pain signals. We want to do that a lot if somebody is suffering and is in pain. This effect is desirable if a physician prescribes morphine to alleviate pain in a person with a terminal illness, or you can think of other reasons why we might want to dull pain. Psychedelic drugs will confuse neurotransmitters by exaggerating and distorting messages and by creating visual and auditory images in the brain. Studies show that the brain images are altered when methamphetamines, alcohol, nicotine, or cocaine are present in the body. All addictive drugs deplete the brain's receptors for dopamine. So that's partially why after you come down off of your high, your dopamine receptors have been depleted, and then you want to kind of rebalance your system, but you can't, so then you go back for more drug. Genetic factors, endorphin and enkephalin neurotransmitters have an opiate-like effect on the brain, thereby causing the individual to experience a feeling of well-being. People who are born with the inability to produce sufficient quantities of these substances have a genetic predisposition toward opiate and alcohol addiction. That goes really a long way in understanding why certain people are more predisposed and why their addiction or disease is going to be more prevalent in some people. These individuals are often diagnosed with depression and look for alternative means to adjust their mood. So they're really trying to self-medicate a condition that they have. So we need to sort of understand the stages of change, the stages of change model. There's your pre-contemplation. So this kind of helps us understand where our patients might be when it comes to their substance misuse. So there's pre-contemplation. They have no thoughts of stopping substance abuse and not viewed as a problem. They may sort of be in an awareness that they are using a substance in excess, but maybe not even. But they certainly are not interested in changing behavior. Contemplation, they think that they should stop substance abuse someday, but not within the next month. So they are starting to feel that, I got to do something, but I'm not ready yet. Preparation, willing to set a quit date and to begin changing their behavior and thinking related to substance abuse in preparation for quitting in the next month. So they really are getting very close. Action, they're really starting thinking about stopping substance abuse for less than 6 months. So they've actually been doing something. It's been a short period of time, but they're actually doing something. Maintenance stops substance abuse for more than 6 months. So they are going to need support. They need reinforcement. They just, basically it's more of almost, they need that support and good job, pat on the back, and whatever they need to continue that stopping of the abuse or the misuse. Relapse, reverting back to substance abuse. So maybe they've maintained it for a while and then something happened and they relapsed. And now where are they? Are they back to pre-contemplation? Are they back to preparedness? Where are they? So patient-centered communication is really important for us. We want to be a collaborative effect. We want to be a collaborative person in their process. We don't want to persuade them or try and convince them. It has to be their decision. Eliciting information, not imparting it. Asking them, do you want to know more about this? I have wonderful information to share. Can I share it with you? Asking permission. Emphasizing the client's autonomy and not the authority of the expert. We're not the expert here. We know that it's their judgment, it's their decision, it's their choice, and really nobody can be more of an expert than the person living with it. And we're not coming from an authoritative place of judgment. We really want to be a partner and help them and maybe provide information to them if they want it, if they're ready for it. So how does this affect the process of care in dental hygiene? So in our assessments, we may try to, or patients may try to pre-medicate themselves. So we may notice when they come in, perhaps they have done something to help them get through the appointment. Maybe they've done something to help alleviate anxiety. Potential need to modify or cancel appointment to avoid any drug interactions or behavioral problems. So we have to realize if they come in off the street and we can tell they're intoxicated, or if we suspect that they have used a drug or a substance like cocaine, we may have to modify our treatment and say, well, you came in for SRP, but I can't give you local anesthetic if you have taken some kind of a drug such as cocaine or something. So we have to think about how the patient coming off the street, we have to think about, sorry, I hope you guys don't hear the background noise. I have some noisy house guests. But we have to think about how the patient coming off the street, if something that they might have taken that they don't disclose to us, we have to be willing to recognize it and then think about how we may have to modify or potentially cancel our appointment if we don't feel comfortable. We want to consider if there's any need for prophylactic antibiotic premedication, if there could be something happening systemically in their bodies, immune suppression, kidney damage, liver damage, heart damage, valvular damage. If they have a history, disclose that they're an IV drug user, they may develop venous thrombosis. They could have organic valvular heart disease. So we have to think about those potentials depending on their history of drug use, what they disclose. IV drug can result in endocarditis caused by Staphylococcus aureus found on non-sterile needles. So this may be more in the case of somebody that is working in a high-risk clinic, like say if you're in a Russell Street clinic and there may be people that tend to partake in riskier behavior, or maybe they disclose that they have used IV drugs before. So it's sometimes not as likely if you're just in sort of a general practice, but it's really, really important to kind of have a general understanding of what this may look like. If somebody comes into your office and sits down and they have track marks, that's like an absolute, clue that you may need to ask some more sensitive questions and kind of be prepared to know how to ask those. Say, I don't want to be intrusive or assumptuous, but I do notice these marks here on your arm. Can I ask you what that's from? And then see how they respond. So assessments continued. Reason for obtaining info is to protect them from health risks, and all information will remain confidential. So you want to share that with them. You want to share, like if you ask them, say this is just between you and me, and anything that you disclose to me is strictly confidential. But I do want to ask this just because some things that I do during this appointment could affect your health if I don't know all information about medication that you took before you came, or drugs that you used before you came to this appointment. So questions for alcohol or drug abuse could include, have you ever felt the need to cut down on your drinking or drug use? Have you ever felt bad or guilty about your drinking or drug use? Have you ever used or had a drink first thing in the morning as an eye-opener, or to steady your nerves, or to just make you kind of feel more normal? If they answer yes to two of those questions, when you ask two of those questions, then you may need to suspect misuse. Substance misuse treatment is not within our scope of practice. So obviously we're going to have a kind of a limitation to where we'll go with that. But what's nice is to be able to support some kind of resources. With so many parts of our scope of practice, what we come down to is we could be a community resource, and that is sometimes the best thing. We can recognize something and then offer resources if the patient is ready. So we want to explain the relationship systemically. So IV drug users, there's a higher incidence of bloodborne pathogens such as HIV, hepatitis B, C, and D. Long-term alcohol abuse, there's liver, heart, kidney, and pancreatic damage. Years of abuse, reproductive system damage, permanent brain damage, lack of muscle coordination. Drug addiction, cardiovascular disease, stroke, cancer, HIV, hepatitis infection, and lung disease. So just letting them know things that really, sometimes it's good to write out your kind of, I always call it a spiel. What would you say to somebody who admits to having a misuse problem but isn't ready to change? You don't want to lecture them. They know it's not healthy for them. So you could say, I've learned a lot about the long-term effects of alcohol abuse, and if you're ever ready to learn more, I'd love to share what I know with you. And then you can share, the relationship between, lack of personal oral care and all the diseases that happen in the mouth, and then how that affects the rest of the body. So you can kind of link it all together for your patient. They just might not realize how one thing leads to another. So sometimes just having that conversation with them when they're ready can actually lead to a lot of positive change. So in the EO-IO, we want to think of things like the appearance of things substantially older. Then we're going to see changes in their mouth that we would see in an age group that's substantially older. So people who are misusing alcohol, misusing drugs, there's going to be a lot more damage typically, especially if it's been a long time. So we might see damage that we would see in an older population. But I don't almost like that statement, frankly, because somebody could be in their 80s and have beautiful oral hygiene and beautiful teeth and gums. And so, you can't just generalize, but they could, especially if they've been a hardcore user for a very long time. Disheveled appearance, potentially. Poor personal hygiene in general, potentially. This is all possibilities, not hard, definite yeses. Wear long sleeve even in the summer to cover up track marks. Alcohol or other odor detected on the breath, kind of that sweet rotten smell, sort of. It's one. I remember I had an alcoholic patient, and whenever he came in, there was just this sweet kind of rotten smell. Lethargic or intoxicated without alcoholic odor. So maybe they took something that's not alcoholic, so they have this intoxicated demeanor, but they don't smell like alcohol. Tremors present in the hands, tongue, eyelids with alcohol withdrawal. Behavior, speech, confusion, disorientation, lethargy, lack of concentration, agitation, impairment. So then some other things that we may see, localized tissue necrosis where the drug has been placed. If they rub cocaine on their gums, they can have gingival lesions. There could be severe bruxism from stimulant activity, like a continuous stimulant use like cocaine or methamphetamines. Often they crave sweets, so we could see extensive caries, especially along the buccal cervical surfaces. Oral candidiasis, glossodynia, tongue pain, poor tissue healing related to immunosuppression, and or poor nutrition. So meth mouth is something you hear about. It's that rampant caries. Usually it starts on the buccal smooth surfaces of posterior teeth, but if it's just gone on and on, I mean, it just can rot out, teeth start breaking. Interproximal spaces in anterior teeth, and then to the complete destruction of the coronal tooth. So it just depends on what stage you see it. Poor oral hygiene, xerostomia from many, opioids cause a lot of xerostomia. So you can see xerostomia in many different abuse with different substance misuse. Gingival inflammation, periodontal disease, if there's just neglect from any kind of visiting, that they're not getting oral hygiene appointments, they're not brushing, they're not flossing, that's going to obviously lead to gingival inflammation and potentially periodontal disease. And then, of course, like I said, the bruxism in taking more sweets. And so a lot of times there's going to be a need for extractions. If they're high abuse of alcohol, then we see xerostomia, poor oral hygiene, gingival bleeding. We'll see all the telltale signs of just general gingival inflammation or periodontal disease, especially if they're prone to that. Not to say they would definitely have periodontal disease, but especially if it's that environmental plus genetic factor plus localized factors, everything just falls in place. If they vomit a lot due to being intoxicated and then vomiting, we may see erosion. So there's so many oral manifestations that could possibly reveal themselves to someone that's misusing an abuse or a substance. So here's just breaking down some more of this in another way: cocaine, meth mouth, or alcohol. So with our appointments, if they are an admitted in recovery, we may definitely need to keep our appointments very short. They even say as short as 20 minutes. So we have to alter what we're going to be able to do. What will we focus on in that very short period of time? The patient just may not be able to handle more than that. And then we have to think about if they're recovering addict, we have to think about pain control. Recovering chemically dependent individuals, pain control is necessary, but how do we go about that? Consult with the physician in regards to local anesthetic safety for chemically independent individuals, especially if they're a cocaine misuser. Unrevealed pain can be a trigger relapse. So if they are in pain and they don't know where to go to for that, the only thing they may know to dull their pain is a substance that they were misusing, so that can trigger a relapse. So postoperative pain, usually NSAID is recommended, but we need to be in consultation with the physician and with other members of the team that are helping them in their recovery. If needed, stronger pain medication, obviously the physician has to be in that conversation. Control anxiety will help reduce perceptions of pain. So different ways to help the patient with the anxiety, that may be, hypnosis or acupuncture, or, different breathing techniques, or there's different things. Be aware of some patients may exaggerate pain in order to get a prescription. That sounds kind of judgmental, and you don't want to just assume that someone is exaggerating pain, but we know it happens, and we just have to be aware of that. Oral health instructions. So begin with basic toothbrush instructions and encourage daily brushing. After this is mastered, introduce interdental. We just don't want to overwhelm them. There's only so many steps that we can take. We don't want to say, oh, your mouth is a mess. We got to do this and this and this. We just got to take it one step at a time, and let them have those little successes so that they don't feel defeated. When making recommendations, we want to consider their physical and mental capabilities, their fine motor skills. Do they have tremors from years of alcohol abuse? What can we do to help them, alter or modify their oral hygiene practices? In recovery, required to make numerous behavioral changes. So we just want to keep it simple and give them those small successes. Xerostomia from antidepressants. So we want to think about xylitol and fluoride. Nutritional counseling, encourage those well-balanced diets, limiting carcinogenic foods. Positive reinforcement always. No alcoholic products at all, nothing that contains alcohol. And methadone for heroin addicts is in a sugary syrup, so we want to be aware of that and then help, encourage those xylitol and fluoride and rinsing the mouth after a use of something with a sugary syrup base. And then, of course, evaluation for possible 3-month recare. If SRP, we want to do 4 to 6 week reeval, and we may want to just encourage short appointments, like every 2 to 3 months. Who knows? We may have to shorten it even more than that just to keep them on a healthy track. And that is the end of that.